I'll share a bit more about what we're doing, but I think most importantly, really looking at it through this lens. So, universal health coverage, that's a big word. Back in 1978, actually, in Alma-Ata, the World Health Organization started to really catalyze this global movement around universal health coverage, and with the objective to achieve it by 2030. So when we talk about universal health coverage is about making sure that we're not letting anyone behind, that every single individual's communities have access to healthcare and have access to quality health services without any financial hardship. So this was back in 1978. Obviously, a lot of years passed, and with this objective of 2030, community health workers have been named as a critical component of the primary healthcare and critical enabler to universal health coverage. In the last 2 years, we faced a huge pandemic, and the community health workers have been able to demonstrate again the importance of their role in being able to ensure continuous health services can be happening at the community level when the hospitals, the clinics are overwhelmed with COVID patients, or when states declare really difficult lockdown and people can't travel, and they still need to have access to that. So Living Goods, we're supporting community health workers, and in the last 2 years, what we've seen is the community health workers that we've been supporting have been able to save more lives because of the pandemic. So they've been able to save more than 60% lives in the community they're serving. So you may wonder how we do it. So initially I had a video, but I've just learned 5 minutes ago that it didn't work. I wanted to bring you in the shoes of Scovia, a community health workers that is working in Uganda, in Budadiri, which is a district, a very rural district in eastern Uganda. And this lady, so she's a community health worker, and she's chosen to do that work and to support her community because it takes more than an hour to walk to the clinic. So meaning that people in her community, if something happened at night, they just don't have health services. They don't have access to that. So they have to walk. But now they have a community health worker in that community. This community health worker has been empowered with training. These community health workers have life-saving medicine at hand. So this community health worker is supervised, so they have support. This community health worker is paid, so she's motivated every month. Yes, she's receiving something for what she's doing. And this community health worker is digitally empowered. So they have a tool to support them to diagnose. So when somebody is knocking at their door in the middle of the night with a sick child with high fever, this person is able to make a difference. So I don't have the video, but I hope that these descriptions give you a better idea. And I think we're in a very nice room here. But let's not forget that what we're doing and what I'm presenting is for the communities in sub-Saharan Africa that are not living in a very nice room with air conditioning, with all the facilities that we have. So what we're doing at Living Goods and really looking at universal health coverage in the last mile, so we ensure that the community health workers have a package of service that they can offer to the communities that they're serving. First of all, health starts at home. Prevention is critical, but prevention is only possible if you have the right level of education, if you know about things. So the community health workers are spending a lot of time educating families about basic things. You need to sleep under a mosquito net. You need to take your child for immunization. So all these basic things that maybe for us is obvious are not necessarily obvious in those communities. And the community health worker role in educating and promoting all those practices, healthy practices, make a huge difference. Then they're also supporting the mothers when they're pregnant, ensuring that they have healthy pregnancies, ensuring that women and male are properly educated around family planning, that they can make choices, that women can choose when they want to be pregnant, that they can have access to family planning methods if they want to. So those community health workers are carrying some family planning commodities, for instance, like Cyanopress, which is an injectables that protect the woman for 3 months. They're also supporting them when children are sick. They can assess a sick child. They can then prescribe drugs for essential diseases like malaria, pneumonia, or diarrhea. Or if there's any danger sign, then they will refer them to the nearest health facilities. But they will also follow up. And that's really the beauty of community health workers being so close to their community, is like if they have a sick child, they prescribe a medicine. Within 24 hours, they will go back, visit this family, visit that kids to ensure that the kids is getting better. And we'll see how, they're doing this. They're also making sure that on a constant basis, if there's any danger sign, then they're referred, again, they went to the health facility. These women, these men, are they health improving? Are they doing better? And if not, do they need to refer them to somewhere else? That's really the package of services that is really essential services. And with the pandemic, we're now growing into disease surveillance. Are there any cases in the family that is unusual? Then if there are such suspicious cases, then how do we refer to ensure that then those people can have access to the health they need? So at Living Goods, over the last 15 years, we've been working across different countries in Africa, starting in Uganda. And what we've done is really to ensure that, and really learn, because there's been a lot of learning on how can we ensure that community health workers can be working more efficiently in a very cost-effective manner. And to do that, we've been reiterating, learning a lot, improving the model and the approach. And what we've codified is really what is critical behind those community health workers to ensure that the package of services that they're delivering, they can deliver it in a very efficient manner. So there's 4 components, 4 pillars. We call it desk, like a desk with a C. And you see, a desk needs 4 pillars to be stable. If there's one pillar that is not there, then it's wobbly and it's not working. So those community health workers need to be digitally enabled, so have digital tools that can help them to deliver quality health services, but also to ensure that as you scale, they will follow the same protocol, whether you're with CHW Scovia in Western Uganda or where you're with CHW Beatrice in Burkina Faso, they will follow the same pattern. Then their supervisors will use the data generated to ensure that then this data can help to improve the performance of the community health workers. They need to be equipped. They need to have the training. They need to have the essential commodities so that they can save life in the community. They need to be supervised. So we need dedicated supervisors for community health workers to ensure that they're delivering quality health services, that they're motivated, and that, again, we're using data to drive the performance of the support that they're providing to the community. And finally, they need to be compensated. Some years back, most of the people thought community health workers need to be volunteers. This is not true. Community health workers are delivering services. They need to be paid. And so the way we've done it is really to focus on performance-based incentive. How do we ensure that community health workers can be paid for the services that they are offering? So as we codified this approach, we've been growing from Uganda, Kenya, and Burkina Faso. So Uganda has been our first countries. We're supporting nearly 9,000 community health workers there, reaching more than 5 million people. And we're now growing into Kenya. And actually, I just noticed that this number is not even accurate. We're now supporting 3,000 community health workers in Kenya, and moving from, in Uganda, being a direct implementation model, where in Kenya, we're now growing to co-financing approaches, where the government, and I think really speaking to Dr. Obi, is like there's co-investment, co-implementation, so that we can drive more sustainability and more of an ownership over the years. And we're now entering into Burkina Faso and setting up a learning site there. Is it working? So we've done 2 randomized control trials over the last 10 years. The first one in Uganda was done when we were very small, and the objective was really to assess, well, this initial proof concept, was it working or not? What we've seen in the first RCT, that the Living Goods supported community health workers were able to reduce under 5 mortality by 30%, by 27%. In 2021, we finished a second RCT, again in Uganda, but with a much broader scale, as we were supporting directly 4,500 community health workers and another 4,000 through our partners. And what we've seen in a country where there's a declining under-5 mortality, that those supported with a desk approach community health workers have been able to reduce under-5 mortality by 28 to 30%. I want to pause here, because 28 to 30% reduction, thank you. And really, this is just a proof, and this was done by an independent organization called Innovation for Poverty Action and JPL. So it's really, I think, a strong evaluation that supports that a desk-enabled community health worker will make a huge difference. So with those results in mind, we've evolved our own strategy to really think about how do we make it more sustainable? How do we ensure that the government can own it more and more? So our approach is around 3 key pillars. The first one is we want to continue to innovate. We want to have learning sites that are center of excellence, that are demonstrating what good look like, but also that we can continue to innovate to ensure that we are preparing for the community health system of the future, and that we continue to test and approach and partner with a number of different organizations to test some new devices, new approaches, telemedicine, I mean, new things that can revolutionize community health approaches. But as we think about scaling and making sure that there's national impact, we need to have implementation support approach where we are working with the government, building the capacity of the government, and slowly handing over and making sure that really they're able to implement desk-enabled community health workers. Because it's one thing to discuss it, to prove it in a small scale, but making it bigger will make a difference. But obviously, if you want to institutionalize things, you need to shape the enabling environment. So speaking to what Dr. Obi was telling us earlier, if you don't have the right policies, if you don't have the right framework, it won't work. So we're also supporting the government at the national level and at the subnational level in a devolved country to ensure that, for instance, payment of community health workers is within the bills, so that then this is institutionalized. And tomorrow, if we're not supporting, it is there, it is in a bill, and they will get paid. So things like this, or we're supporting also in the development of the community health information system. How do we ensure that the right infrastructure is in place, that they have the right capability to be able to grow this electronic community health information system? So this is for us critical to make sure that then we will enable resilient government-led community health, that government will be being able to implement efficient community health system, but not only implement, they will be able to finance them, to unlock some funding. And what we've seen, I'll just share an example. I was in Kenya a few weeks ago, and we are implementing across different counties. But there's one county that I visited, Kisumu County, where we have a co-financing agreement. So it's a 5-year agreement where we are over-investing at the beginning and then decreasing our investment over the years, and the county is increasing their investment. The governor, the chief of health, down to the sub-county health-focused person or community health-focused person, they were all able to talk about data-driven community health. They were all able to use the dashboard. Every Monday morning, they have a meeting. I've attended those meetings, and they are all the government people are the one presenting this data. This is data that is collected by the community health workers. This is But this is data that they use for decision, that they want to improve, that they want to use to improve the health of the community that they're serving. So looking at really where we're going, this is the only way to drive durable national impact. And we want to make sure that then data is properly used. So community health workers are essential to universal health coverage. But obviously to reach universal health coverage, it's not one intervention that is going to make the difference. We need to have several interventions, and that's a combination of those different interventions that will make a difference. So I'll pass it over to Healthy Entrepreneur and the health clinics.
Good morning. Thank you, Emily, for your presentation, introduction to the important work of community health workers. I would like to continue the conversation Emily started by introducing myself. My name is Joost van Engen. I'm founder of Healthy Entrepreneurs, an organization founded 10 years ago that works actually on improving community health, very much focused on last mile areas. I first of all would like to thank the Bayer Foundation having me here today. It's an honor and it's a fantastic event, meeting so many people who are all in it for the same cause. So thank you. The story about Healthy Entrepreneurs is actually about a vision that we all share, basic health for all. And in our case, we do so by empowering micro-entrepreneurs to offer and deliver effective and affordable health products and services in hard-to-reach and remote areas. And yes, those micro-entrepreneurs are actually community health workers. The reason we do this, because there is a challenge. And we've been talking about skill today. And Dr. Obi, you're completely right. When we take today the market, in sub-Saharan Africa, there is around 600 million people living in hard-to-reach and remote areas, where at least 5 kilometer distance to the nearest health facility, a low level of informed demand, and it's expensive, because we are talking about funding, but we know the funding isn't there. People are spending out of pocket around 15% of their monthly income to access healthcare. All out of pocket. And so, if you take those 600 million people, on average 5 in a family, we will talking about 120 million families. They're all spending, on average, $100 a year to access healthcare. $100, out of which 55% are transport costs to actually access healthcare. So the most vulnerable people in the world are actually spending a lot of money just to access healthcare, just not even to get the treatment. And so there is a market, 120 million families, times $100, 12 billion, currently spent out of pocket. And that's where Healthy Entrepreneurs says this is a burden, but also an opportunity. By offering services closer to home, we are able to give more than 55% savings on expenses to healthcare. And that's actually where we are building on. The existing out-of-pocket expenses, reducing the amount of money spent by offering healthcare services close to home. And we do this by organizing a very traditional business model. We are buying and selling, organizing through a supply chain, end-to-end products, procured internationally, regionally, locally, kept in our warehouse, and then using the entrepreneur, the micro-entrepreneur, to serve their end customers. And yes, of course, this is where technology comes in for efficiency purpose, for control purpose, for supervision purpose. The model we offer, and very much referring to what Emily mentioned just now, we need to empower community health workers. We need to equip them, and that's what we do. We give them an opportunity to become an entrepreneur and part of our network. An entrepreneur that first starts to decide to take an investment in us, instead of waiting for the free money to come. They decide on purposely to actually take the opportunity to invest in us, and in exchange, we'll give them training at the start, and we'll continue training them over time. We'll give them access to products. All the basic health commodities which are needed to offer life-saving treatments are offered every 2 weeks. They're offered on credit. And as we work mainly with women, organized in groups, as we've just learned, we are able to have a very solid base of people we are dealing with. We also use technology. Technology, a smartphone, to actually place orders, to manage stocks, and actually make payments to us, but also to support the quality of healthcare by health education, health support, and other activities, including telemedicine. And this all leads to our customers who are actually benefiting by increased income and actually access to healthcare. The assortment we offer is actually very straightforward. There is a number of over-the-counter medicines, including anti-malaria treatments, pain-killing, but also deworming. There is sexual and reproductive health, a key product, one of the few items we are offering for free, condoms, oral contraceptives, and injectables. We're having a full range of fortified products for pregnant ladies, for people with low resistance, and also for children. And we have personal care products. And it's important to realize where we operate. And so take this is the town, this is the city. And that's where we do not work. We only operate where we are able to add economic value. So we branch off and we get into rural communities where we have organized ourselves in clusters of 20 entrepreneurs, where we are adding economic value for them, where we are serving the ones who are having this long walking distance. What we have also developed and actually tried to offer is more value-added services in communities. And that's where telemedicine comes in. That's where once the vitals are checked in the community by the entrepreneur, I refer to blood pressure, I refer to blood sugar, the information is shared with our teledoctor at distance who keeps track on the patient. But also he is able to send an e-prescription to the patient and to the entrepreneur, who will then in a controlled way, using our latest innovation, the e-dispensing solution, having a complete controlled way, comparing the patient with the e-prescription and the packaging of the treatment he needs in order to make sure that we are able to have a complete controlled dispatch of prescription drugs to the remote villages. Aging people can save more than 90% of the expenses for treatment for hypertension and diabetes by just being treated through us. And we're asking the local diaspora to pay us to make sure we look after their elderly people. So what we have reached so far, we are offering 55% cost saving for more than 12 million customers. We have sold more than 32 million impact products at a 15% lower price. And we were able for more than 10,000 entrepreneurs to double their income. And that's the reason why the WHO has identified healthy entrepreneurs as one of the top 10 innovators for primary healthcare. It's true, I'm honestly very honored and impressed that we were able to do so. And sometimes I feel like, why is it us that is actually doing so? And why it didn't happen before? But that's actually, I believe, that there is an enormous market opportunity out there. But for whatever reason, the lack of policies, actually free products promised and in practice not happening, is actually why this market has not been designed and not been developed. But all the manufacturers, all the suppliers, they're supporting us by giving us the very best prices, the very best conditions in order to serve our communities, because everyone is aware that there is an enormous unmet need. And well, the only way to do so, to operate at large scale, is to have this private invested model, because that's what we are. We need to have the private sector, and we are a business, we are a social business. I'm not in it to make my own money, I'm in it to use the business mechanism to operate at scale. And that is also what was referred to this morning. We talk about telcos, we talk about other large organizations. Well, we are becoming one of them, because we are ambitious. And this is our growth plan. We are growing from more than 10,000 entrepreneurs today, 15,000 end of this year, up to 250,000 entrepreneurs by end of 2030. And yes, it's true, it's ambitious, but I believe it's very much possible. And it was Dr. Obi who made this event very effective. Because, Doctor, it is true, healthy entrepreneurs will grow in the blue part, and we will manage ourselves in more than 15 countries, 150,000 entrepreneurs, easily. But there's areas where we don't want to go. We need to have third parties to take over. And already the first conversations start because the model has the potential to grow. It's financially investable, you can make something out of it. And if we do very well, maybe in 10 years from now, Unilever will come and actually take over the whole thing because it's important to get those products there. But we need also third parties to operate. And Doctor, if you commit to what you told me yesterday, and we just get into Nigeria, the two of us, we can actually do this whole part together. And you are with me on scale, because it's about scale. And the only way to get this scale in place is to get the right investments in. So I'm not standing here just to raise my 15 million, but I wanted to show you how affordable it is if you invest in an investable business model. Because with 15 million euro only, we are able to expand up to 90,000 entrepreneurs by 2027. We're having a full telehealth and e-dispensing solution implemented. We are operational in more than 10 countries, and we are on track to reach our 250,000 entrepreneurs by 2030. And by only doing so, we are able to save more than $6 billion until 2027 for more than 100 million people. So if you think about healthy entrepreneurs, we are not in healthcare provision. We are in poverty reduction by offering healthcare. So there is a lot of win-win in the model we are operating. And Emily, I agree with you. Everyone wants the community health worker to be paid. They deserve it. They're fantastic people. I love them. And every time I go in the field, I realize again how important they are. At the same time, waiting until the funding comes, it's going to take too long. So I think we better get into the private investment model, and I really would like to work with all of you, developing technology, supporting tools, and operating at very large scale. Thank you.
I'm really pleased to be here, and I think it's really special to be able to share a stage this morning with Emily and Joost talking about community health work and the really critical role that community health workers play in universal health coverage. And I want to set the stage a little bit more because there are some statistics that are really important for all of us to understand the context. And one of those is that half of the world's population cannot access basic essential healthcare. And 1 billion people alive today will never see a doctor in their lives for any event. So we know that that care gap is being filled somehow. And what we're here to say this morning is that that gap is being filled by millions of community health workers. Some of them are fortunate enough to be in well-supported systems like you've heard about this morning, but for the majority of community health workers in the world, they don't receive formal training, or if they do, it's maybe 2 days of in-service training, and then they're just sort of left out into the world, and they say, go take care of your village and go take care of 500 people. If you were told you are now responsible for providing the primary health for 500 people in your community, how would you do it? How would you answer the questions? How would you answer the door in the middle of the night when a pregnant woman who lost her last child in childbirth came to you and said, I have a fever, or I'm bleeding, or my 4-year-old has a fever and I don't know what to do? What resources would you want? And we're fortunate in a position to say, well, we can advocate for better support for community health workers. And one of the ways that we can do that is by making the care that they're providing visible. And I'll start with the example that all of us can kind of relate to in COVID. As we're monitoring COVID around the world and we're monitoring cases, those case numbers that we were all tracking to see, like, oh, where are the hotspots globally? What's happening in my community? Every one of those cases was a test that was taken in a facility. So if you've got half of the world's population that can't access a facility, how are we tracking health outcomes? And how are we tracking disease monitoring? And how are we working to prevent future pandemics if the care being provided is invisible? Or if it's not invisible, it's stacked in papers in offices that are chock full of backlog data, of tests that have been run, of people who have come in, and there's no visible tracking, there's no integration, there's no visibility into what the national needs are for the communities that are the least resourced. So we are a partner in all of this. As Emily talked about, there are a lot of interventions that are necessary, and Medic has a small corner of that. So we build open source digital tools for community health workers. And our approach here really starts with human-centered design. Because when we're talking about community health workers, we are talking about people who have never had a mobile phone before, or they might not have ever had a smartphone, or they might be illiterate. So when we're designing tools, we have to design them in a way that they will be used. Because if we aren't designing for the end user, then what's the point? If you're making a community health worker's life harder with your tools, they aren't going to use them, and then it's all for naught. So we start with a human-centered approach and participatory design, which means sitting down with the health workers who are going to be using the app, saying what are the needs of the community, matching that up against what are the needs of the national governments or our partners, and saying we need to be tracking disease monitoring. So we will also work in solidarity with governments, with NGOs, and with technical organizations, and say, what are the best practices that you have? What are the other wraparound services that can be provided? And also, what needs to be monitored? Because we're walking into a situation where a community health worker might be empowered with digital tools, but she might be walking into a household with one phone from the Malaria Consortium, one phone from UNICEF, one phone from PEPFAR, and one phone from someone else. And she has to walk into a household and say, I'm at this household, there's a woman, she's pregnant. I'm at this household, there's someone with a fever, with these things. by creating a tool that has holistic capacity to address all of the use cases that a community health worker is empowered to provide, that means that you're reducing redundancy, you're capturing more information, you're providing more complete care to a household within the catchment area. So working in solidarity with our partners to say what's needed on a health system level. And then we have this commitment to building open source resources to encourage local ownership and sustainability. When we talk about that small is no longer beautiful, like we have to talk about scale, MEDIC is really committed to not doing this alone. We know that the gap to fill for community health work is so large. There's just so much work to do, and we can't and we won't do it alone. So by making everything we build fully open source, I sent the website to Joyce this morning and just said, you can go and get a reference app. Anybody with technical capacity can go onto communityhealthtoolkit.org and go see a reference app for antenatal care. They can go see a reference app for supportive supervision that's aligned with WHO best practices, that's aligned with the 120 different community health projects that we've been involved in for the last 10 years, and everything we've learned along the way to empower anyone, whether it's someone working in a refugee community and they want to say, you know, what are the best practices? We want to somehow support them. We don't know where to start. We have a developer. We heard you do some digital tools. Where can we start? So you can start with a reference app. And that can turn into a really highly functioning system like Living Goods has. Their Smart Health app is in Kenya and Uganda built on the CHT. And it can also just be something really simple, one workflow. If that's where you start, fantastic. But it can be similar to our model with Muso in Mali, where you have a proactive case management system. You've got universal health coverage mode, which is just a product innovation user interface that increased universal health coverage by 50% in health workers that were already seeing really massive gains in health. So ensuring that everything that we learn comes back to an open source community is really critical to this idea of sustainability. It also means that there's no proprietary tool that when scaled suddenly becomes too expensive. Because if you start with a proprietary tool and you say, yes, it's open source, it's free for your first 50 users, then when we're working with the national government in Kenya alongside Living Goods, and we're working with the national government in Uganda or Mali or Niger, Cote d'Ivoire, Togo, Nepal, any of the 15 countries that we're working in, and the national government says, great, we want to use this. We want to scale this to 95,000 community health workers in the next 3 years. If you've got a licensing fee of $1 per license per month, you've now got an ongoing expense of $100,000 per month in a health system where you're struggling to buy phones, to pay health workers. The cost just becomes too much. So having an open source platform helps a little bit with that. And then we have proven improvements in coverage, quality, equity, and cost effectiveness of care. The RCTs that Emily spoke to are part of that evidence base. Part of it is our work with partners in health in Malawi, our partners in Mali with Muso, our partners in Uganda and BRAC. It's shown that digitally empowered care workers can make care visible. They can have real reduction in maternal and child mortality. They can be responsible for case management. They can be empowered to monitor for disease transmission. They can be empowered to follow up on HIV-ART treatments. They can be empowered to do this work with the right tools and the right capacity. So what do the tools look like, and what are we really talking about? We're talking about building and scaling health systems faster and cheaper. We went into a country a few years ago and said, how much will it cost to build a digital community health system? Because they had just gotten off the phone with McKinsey or one of these big consulting firms, and they had been quoted $100 million to build their community health information system. The community health information system that we're building for national scale in Mali will cost us 1% of that. And the tools that we are building are built to support multiple languages, so they can be immediately translated easily. They run offline. So when we're talking about areas with really limited availability and network coverage. So they can work offline, you can capture all this data, and then when you come back to a place of connectivity, great, upload everything. They work on basic phones, starting with basic phones, as Dr. Abhi mentioned. In Nepal, we have over 10,000 female community health volunteers that are using basic phones with SMS texting workflows, still having a huge, tremendous impact. They support multiple hierarchies. They can be integrated into the digital health ecosystem, so they can be integrated with stock monitoring. They can be integrated with facility-based care. They can be integrated with DHIS2 to level up to the national government scale. And over 86% of the WHO digital health interventions, which is not a phrase that probably many of you need to deal with, are now covered by the CHT. So what does this impact look like? The big number here is 75 million caring activities all time. A caring activity might be registering a household. It might be providing an immunization. Caring activity is checking in on a pregnant woman to make sure that she's planning on a facility-based birth. It's following up after that birth to make sure that you're having the postnatal care visits with the woman and the child. So each one of these 75 million moments of care is a moment that otherwise might have been completely invisible to the global health system. Right now, we have about 40,000 active users on the CHT. When we talked about the difference between users and active users, we've got 40,000 active CHT users. They're providing care to 6 million households in 15 countries. And you can see on the map, kind of we've added stars where we're working with the national governments to scale nationally. So these national governments represent around 400,000 community health workers that will be onboarded to CHT tools in the next 5 years. And so a 10x scale in the next 5 years just by working with governments in solidarity with partners like Living Goods and others in a coalition approach to ensure that we can scale proven impact. So thank you. Back to you, Adrian.